Welcome to the Critical Care Obstetrics podcast. I'm Stephanie Martin, Medical Director at Clinical Concepts in Obstetrics, and I'm here with my partners, Suzanne McMurtry Baird, Nursing Director, and Julie Arafeh, Simulation Director for Clinical Concepts in Obstetrics. Today, we're going to be debriefing our recent podcast episode, A Diagnostic Dilemma, Peripartum Cardiomyopathy, or Preeclampsia with Severe Features. And in that podcast, I interviewed a postpartum woman with pulmonary edema that had been given a diagnosis of peripartum cardiomyopathy, and we really kind of questioned that diagnosis. I want to point out that we are also joined by a new partner at Clinical Concepts in Obstetrics here on the podcast. Her name is Dolly. For those of you who follow us on social media, you've met Dolly before when she went for her first little puppy vet visit, but you might hear Dolly contributing as she snores following her very heavy breakfast of toilet paper and cardboard. And those of you other pet parents out there can completely empathize. We were just thanking goodness that it's not COVID times where toilet paper is as valuable as eggs.
I know. So, I wish I would have developed toilet paper for dogs, for puppies, and I'm going to have to lock it up because I have like little pieces of toilet paper all over the house. And I'm just go around and I see an unrolled roll just going down the hallway. I know I'm in trouble. So she's under my desk snoring. And for those of you who hear something in my background, I never know what she's going to do on here. So I apologize in advance.
She's always entertaining, and she has some good points. We'll just bring her.
I'm just glad you think it's entertaining. Like I had forgotten about puppies, but anyway, she's a toddler.
That's why I got an adult cat when I got my kitty.
Good gosh, it's keeping me on my toes.
Okay, so let's dive in. So, to summarize, the case that we reviewed in the last podcast, the patient experience, she was not a medical professional at the time she gave birth, but she subsequently became a labor and delivery nurse, which I find so absolutely fascinating that you would have this medical experience and then feel comfortable or driven in some way to become a nurse and an L&D nurse, no less. That was really awe-inspiring to me. But she had an uncomplicated term vaginal birth. She did have a lot of edema through the pregnancy that was fairly significant, that she described pretty significant pitting edema towards the end of the pregnancy. And I think I said she had a vaginal birth, but she had a labor and then ended up having a cesarean for her failure to progress in labor, and the baby was not tolerating the labor, et cetera. So postpartum, she had some shortness of breath and fatigue and was not able to lay completely flat. She was ultimately sent home and readmitted with hypoxemia. She spent several days in the intensive care unit with BiPAP and was labeled with a diagnosis of peripartum cardiomyopathy, preeclampsia with severe features, spinal headache, and pneumonia. So those were her discharge diagnoses. And I did review her records, so those were actually the discharge diagnosis, and she confirmed that as well. So you guys really think that's what was actually happening?
I know when I was listening, and I have not reviewed the records, but when I was listening, I thought out of all of these, what would be the most common? What do we see all the time? But if you come in through the emergency department, or if you go into an adult ICU, that may not be obvious to them. So I think that's what I was thinking when I saw that list. I mean, that's 1, 2, 3, 4 different diagnoses with the same, kind of symptoms or leading to down one path.
Yeah, I think when we think about preeclampsia, there are so many ramifications of preeclampsia because it's a multi-system organ disease and can present in so many different ways that I think if you're not familiar with preeclampsia with severe features, I think you can be easily fooled.
Yeah, and I think it just depends on your experience with those patients. So also some of our smaller hospitals that may be listening, if you you may have an ICU in your hospital, but they probably don't see that many either pregnant or postpartum patients, or those patients are transferred out to a higher level of care outside for, you know, management by MFM or at a larger hospital with more resources. So that can actually happen in some of our smaller hospitals. And we've seen that. We've been the recipients of receiving those patients into tertiary care centers as well. So I think that plays a role in why so many of the 4 diagnoses.
Yeah, and in this situation, there was an obstetrician involved in her care, but very often when patients readmit or represent postpartum to a non-obstetric location of care, there may not be an obstetrician or anyone who's familiar with obstetrics involved. So you're much more likely to get these lists of it's I think Suzanne, you said it's almost like a differential list. The differential diagnosis list became her actual diagnosis list, when it's really the differential list is just your starting point to consider the possibilities, but it doesn't, you shorten that down, and it didn't seem to get narrowed down much even after they did further workup.
Right, right. And, you know, it's almost like you have a diagnosis for every symptom. You know, she had a headache. So, oh, well, she had to have a spinal headache, you know, that kind of thing. So it's not, to me, it's kind of like critical thinking too, you know, in your differential, you make these differential diagnoses, but you got to then critically think and think, what is the most common thing that this could be in a pregnant or postpartum patient? And this patient happened to be postpartum. And I think out of that list, we think preeclampsia with severe features. But again, if you don't see it that often, then you may miss that and think zebra. Let's look for the zebras in the diagnosis.
Let's have 4 zebras.
Yeah, 4 zebras.
Or 3 zebras and a horse. Okay, so
Yeah.
we've got 3 zebras and a horse. So, I mean, this is, for those of you who are familiar with Occam's razor. Occam's razor is the understanding that the simplest explanation is the most likely explanation. If one thing can explain all of these things, that's probably what you're dealing with. And in this situation, preeclampsia with severe features can explain everything except the pneumonia. We'll talk about the pneumonia kind of towards the end. So let's kind of build the case for preeclampsia with severe features and not that this was peripartum cardiomyopathy. So postpartum, there were a few red flags before she was sent home. She was short of breath. She couldn't lay flat. She had a headache, and she had pretty severe edema by all accounts. So I'm not saying that you can't send a patient home with each one of these symptoms, but you can't send a patient home with each one of these issues without doing additional evaluation and assessment to determine whether this is pathology or not that requires further evaluation. So, Suzanne, Julie, who wants to weigh in? How would you assess a patient for these symptoms to know if they're ready to be discharged? And what kind of things do you want to know before she goes home?
Well, first off, I just want to say that sometimes we get so in our mindset, it's day 2 and it's time for you to go home. It's day 3 or 4. And based upon our pathway, it is your day to go home. And we start to see some of these symptoms building in the postpartum period. And again, I don't know if this is a result of our EMR or communication or team, or I don't know, but pulling it all together is what I see as an issue in this case. It's a failure to pull it all together. So if I had a patient and I'm the postpartum nurse and I have some of these red flags, shortness of breath, for instance, what do I want to look for in addition to the shortness of breath? So what is her respiratory rate? What is her blood pressure? What is her heart rate? What is her temperature? You know, those vital signs are vital. Number 1. Number 2, what does her breath sound like? You know, and again, we're talking about listening through the posterior regions, all regions of the lungs, both left and right side. That requires the patient to sit up. That requires your stethoscope. That requires a full assessment. What do they sound like? And they could be really faint at this stage, or she may not have any crackles or adventitious breath sounds at all, but you want to assess and you want to document that you did that assessment. And I think putting it together with that cannot lay flat. I want more information. What are you talking about with that? You can't lay flat, or combined with your shortness of breath.
I think as well, and all of that is excellent assessment, which I'm not sure happens every single time, but that's what should be happening. And in addition to that, what is the patient's perspective on all of this? How is the patient feeling? Is she feeling fine and she's ready to go home? Or is she uncomfortable? Does she not feel well? And I think even though that's a very soft assessment finding, it's powerful because this patient didn't feel good. She had a headache. She couldn't lay flat. So it wasn't like she was anxious to go home and ready to go home and assume care of a newborn. She didn't feel good.
Right, and the edema too. And we see edema quite frequently. I mean, in the postpartum period, especially because your serum albumin is going to be lower. So your colloid oncotic pressure is going to be lower, and you will third space a lot of fluid. But does she have just dependent edema? Is it going down? Is it getting worse? Again, I think just that full assessment, and to make sure that the clinician who is discharging this patient knows that this patient has some red flags. And that all should then drive your postpartum teaching, or if you have postpartum discharge criteria, does she meet that? And again, I don't have her vital signs, but that would be where I would start along with her breath sounds. The other thing that you could do is take a pulse ox value. Sometimes you may or may not have a pulse oximeter machine on a postpartum mother baby unit, but get one. Have one, get a machine up there and evaluate that before you send somebody home.
Yeah, and when she goes home, she needs to be sent home with very specific written and verbal information about when to follow up, ideally with an appointment already made. And that follow up for a patient like this who's not going home 100%, feeling 100% with significant edema, et cetera, I would want that follow up to be sooner rather than later. We're not going to see her at 6 weeks. I want to see her within 1 to 2 weeks. If she's hypertensive, first of all, I guess whether or not she's even going to go home. But let's say that we do the assessment and we identify hypertension that maybe wasn't identified before. She needs to be seen in a few days. If somebody's got any kind of hypertensive issue, antepartum, postpartum, whatever, they need to be followed up, within several days, certainly no longer than a week from discharge to reevaluate them. And really clear instructions about what is she looking for? When does she need to come back? When does she need to seek care? Be specific for them. She's got a newborn and she may have other children at home. So, this is not, you can't expect her to just keep this all in her head. It needs to be communicated in several different ways.
Yeah, and there's several tools out there that you can use. A1 has a post-birth discharge algorithm and clinical clues on when a patient should seek medical care during the postpartum period. There's also a CDC early warning signs document as well. So make sure that you have something.
Yeah, and in my experience, patients, once you send them home, they've got an issue, they've told you about this issue, they're not feeling 100%, you send them home. It's almost as if you are blessing how they are currently doing. And it's harder for them to pull the trigger to come back in after that. And very often they're going to get to a very far advanced point in their symptoms where either they can't say no anymore, or a family member is now overly so concerned that they are not accepting no for an answer. It often has to get worse than it needs to be. So this is where we have a responsibility to make sure that patients are ready to go home before we send them home, and that we give them very clear instructions and permission to seek care if they're not getting better.
I think the permission thing is huge too, because as a new mom with a newborn and you're exhausted and they're like, oh, I'm just tired. I'm just tired because I'm not getting a lot of sleep, or I'm post surgery, or I'm postpartum, hormonal changes. I mean, you go through all of that, and I don't want to show up and nothing be wrong.
Yeah.
And I think giving them permission and encouraging that, because it is, when you look at the maternal mortality data in the postpartum period, the number one thing, or one of the big categories that they've looked at, is being the patient didn't know when to call or come back in.
I think too, if all of these instructions can be given in front of a family member who's going to be with the patient, I think that's really important. There are times, I know with my own family, I usually sit in on appointments and I pick up things that they don't pick up at, and I
Right.
remember things that they don't remember, or I remind them, oh, remember we were supposed to call about this. Oh, they forgot about that. And I think it's important that the main person who's going to be with her when she goes home hears this as well.
Yeah. Unfortunately, I think there's a lot of patients who don't have that support at home.
Yeah.
And we're seeing that a lot with some of the social determinants of health, or patients going back to work and all kinds of things that are required, or their support person going back to work.
So I think you're all kind of hearing from us that we're very suspicious. We believe that her symptoms really all fit a pattern of preeclampsia with severe features. So let's just kind of recap. What is preeclampsia with severe features? So let's start with preeclampsia. Preeclampsia is blood pressure of greater than 140/90 after 20 weeks gestation that's sustained at 4 hours apart with protein in the urine. She clearly had both of those things. There are certain criteria that then make it severe. Severe hypertension, so blood pressures of greater than 160/110, low platelets, less than 100,000, abnormal AST and ALT, severe right upper quadrant or epigastric pain. Renal insufficiency usually shows up as creatinines greater than 1.1, or if it doubles from their baseline, if you know their baseline. Pulmonary edema, new onset headache, and visual disturbances. So she had multiple of these things. She had severe hypertension. She had elevated liver function tests. She had pulmonary edema, and she had headache.
Yeah, I think the one thing that she didn't have, I think her platelets were normal, right?
Platelets were normal. You don't have to have all of these things.
Exactly.
You just have to have any of these things.
Exactly.
Yeah.
And I think that's a diagnostic dilemma that a lot of people have, is they're like, well, her platelets are normal, or her liver functions are normal. And then you have something else though. And I think the one that sneaks in there is that severe headache, that is unrelenting, and, again, the hypertension in some of these patients, it doesn't have to be such severe range. In fact, some of the sickest patients I've ever taken care of were not that hypertensive, but they had severe features in other ways.
Yeah, so I mean, everything that she had is pretty consistent and classic for preeclampsia with severe features, which can absolutely happen in the postpartum period. And in this case, it looks like it did.
Yeah, I think too is just remembering back to the pathophysiology of preeclampsia, that it, like Julie said earlier, it's a multi-system organ disease state. It mimics a lot of other diseases, so sometimes it throws off the diagnosis, and it's a weird, wild disease, because if you think about it, the vascular injury that occurs throughout the body in these patients can be severe or it can be minimal. So in those severe vascular injury patients, they're going to have more manifestations, more symptoms that you see that should not be explained away. And again, a lot of times we focus just on blood pressure and they go, well, she's not that hypertensive, but she's got all these other vascular injury clinical clues like pulmonary edema, like severe headache that's unrelenting. That's all due to vascular injury. She's got generalized edema due to vascular injury. So it that's the key. That's the key part of the pathophysiology is that vascular injury leading to all of these multi-system organ failure or involvement.
And I think we have to keep in mind too, she's postpartum and she was swollen. She had a lot of edema before she came in. So you know that after pregnancy, you start to have fluid shifts. So when you have more fluid that's in the third space coming now back into the vascular space, and you've got all of this endothelial damage, that fluid has to go somewhere.
Yeah, I think that was key for this patient too. You know, she had pulmonary edema, and it was from preeclampsia, but you start pulling that fluid back in intravascular, and your blood pressure is going to go up. You're going to really dilate the heart. You're going to over distend the myocardium, and that fluid will start backing up in the lungs. And that's where it's forced out of the blood vessel into the extravascular space, where you can get a cardiogenic pulmonary edema as you start pouring that fluid back in. So that matches the clinical picture that I think this patient presented with.
Plus, she had labor, then ended up with a cesarean. She very likely got some fluid boluses that contributed to that, and then the autotransfusion effect that happens postpartum. So all of these things are kind of contributing. And you'll remember that she had very low oncotic pressure. Her albumin was very low and her hemoglobin was very low. So she, is not, and she was spilling protein, so she's losing her ability to hold fluid in her blood vessels. All of it's like a perfect storm. This is why preeclampsia is that perfect storm where all this stuff can happen.
Exactly. And Julie and I remember when we had a lot of Swan-Ganz pulmonary artery catheter patients, and we would see another clinical picture with a patient with preeclampsia, and that would be a myocardial depressant clinical picture where you would optimize their preload or their intravascular volume. You would optimize their blood pressures, and they would still have a depressed myocardium where you were seeing that clinical picture of what some may think is a peripartum cardiomyopathy, but it was really related to the preeclampsia, or I think in this patient's case, it was related to overstretch of the myocardium.
Yeah, and we see all the time in reviewing records and where any patient with any kind of, quote, heart failure, end quote, in and around pregnancy is labeled with a peripartum cardiomyopathy because they are peripartum, which is absolutely inappropriate. And everybody needs to understand that just like preeclampsia has very specific diagnostic criteria, so does peripartum cardiomyopathy. And peripartum cardiomyopathy is almost a diagnosis of exclusion. In other words, there are three major criteria. The first is development of heart failure in the last month of pregnancy. And by heart failure, we mean pulmonary edema. Or towards the end of pregnancy, or within 5 months following delivery. We know that peripartum cardiomyopathy can happen what appears to be remote from delivery. No other identifiable cause for the heart failure. That's not the case here. And the echo needs to show an ejection fraction of less than 45%. She did not meet these criteria, ever. But we see pulmonary edema, and she just had a baby, therefore it is peripartum cardiomyopathy. Suzanne and I were talking earlier, we've had patients who are literally post-cardiac arrest, or post massive transfusion from hemorrhage, and it impacts their cardiac output, their cardiac function, and they get labeled with peripartum cardiomyopathy, which makes absolutely no sense. They've literally not been supplying oxygen to their heart muscle, and they're in shock. Why on earth would they have a normal ejection fraction here? This is not peripartum cardiomyopathy.
Exactly. And I think too, the peripartum cardiomyopathy is such a large diagnosis. And I say large because it's looming also. So, and we'll talk more about that in a minute, because I think we've got some thoughts on that.
So there's several things that make us think that this, well, first of all, we're pretty convinced this is preeclampsia with severe features for all the reasons that we've just said. Then the question is it cardiogenic or non-cardiogenic? You guys know we don't like to say pulmonary edema. We like to be more specific, cardiogenic or non-cardiogenic. And there's several things that make us think that this is cardiogenic. She had a very elevated BNP. And if you'll remember, BNP is B-type natriuretic peptide. It's released by the ventricles in response to increased pressure and overstretch. So it reflects a heart under pressure. There's lots of fluid in the heart, lots of volume. And she had that. Her echo showed systolic and diastolic dysfunction, which can be due to volume overload. And the fact that it was preeclampsia and the way she presented, it all makes us think that we've got cardiogenic pulmonary edema. The other part was the fact that she's misdiagnosed with pneumonia because she had bibasilar infiltrates. That's cardiogenic pulmonary edema.
Yeah, it settles at the bases. It's not throughout the lungs. It's like your lungs are a gas tank and they fill up from the bottom up. And then when you diurese them, it falls down like a gas tank too. It goes to empty. So to me, it completely matches the picture of a cardiogenic pulmonary edema due to preeclampsia. And it fits that timeline too with preeclampsia, that, timeline of pulling that fluid back into the blood vessel, like we said before.
Now, if this is a bit much to digest in this podcast setting, remember we have the Critical Care OB Academy that goes into all of this in a lot more detail, lots more information with visual aids, obviously. And we have tons of downloads that are included in the course, including algorithms for figuring out whether this is cardiogenic or non-cardiogenic pulmonary edema. We've got checklists to help you navigate this. So lots of resources for those of you who want to learn more about this. Expanding on this pneumonia diagnosis, she didn't have pneumonia. She had a bibasilar consolidation, but she had no fever, no white count, no other signs of infection. This was cardiogenic pulmonary edema.
Yeah, I see that a lot. Don't you see that a lot in case review? I see a lot of diagnoses of of pneumonia versus pulmonary edema, and the patient literally has no signs and symptoms of infection, right? They have an abnormal chest x-ray, but they don't have any fever. They don't have any elevated white count, or they're not coughing up, mucus and phlegm, and, it's not a productive cough. So it just doesn't fit the clinical picture.
And a bibasilar pneumonia. Most
Right.
patients who get pneumonia, it's one area. It's not
Exactly.
both sides in both bases. So this is just kind of lazy, in my opinion, labeling it with pneumonia.
Yeah, but it's common.
Very common.
That we see that.
So do we really think she had a spinal headache?
No.
That would be no.
I agree. I mean, most over 90% are going to happen within 72 hours. She was kind of on the cusp for that. And the classic spinal headache is that basically that's severe when they're sitting upright, and when they lay flat, it essentially completely resolves. They typically need a blood patch for this. But what's the likelihood that this patient had a peripartum cardiomyopathy, preeclampsia with severe features, pneumonia, and a spinal headache? This headache was preeclampsia.
Yeah.
We're talking zebra.
The patients that I have taken care of with a spinal headache, you cannot get them to sit up. They literally will not do anything but lay flat, because that's the only way they feel comfortable. And she couldn't even lay flat.
Hmm.
Yeah.
Yeah, I think while she was in the hospital, she would have shown signs of a spinal headache it's so severe too. Those patients are photophobic. I mean, it is so severe, that headache.
Yeah, I like to the way I think about a spinal headache, and I that gives me like perspective on why it's so severe and their symptoms. And I could be totally wrong on it. Just the way I process it is that the fluid is leaked out, so the cushion to the brain is gone. And when they're sitting upright, the brain stem is literally resting on sharp bone. And when they lay flat, it's resting on smooth, flat skull. That's the way I think of it visually, that explains why they're in so much pain. But yeah, like the brain is like resting on the bony base of the skull. It's not
Ugh.
cushioned the way it was. It's a severe headache.
Okay, now I can't unsee that. Thank you. So for that description, I am like, I don't ever want that.
No, but when you see a patient with this, you can't help but feel for them. Like they are, but
Oh,
it's if you've never seen it before, it can be hard to imagine how somebody just lays flat and their headache's just gone.
right.
But it is.
Yeah, yeah. And we've all seen patients with it. It's something else. But again, I think this requires critical thinking through the other things that are going on with this patient. I mean, she's hypertensive. She's got pulmonary edema. She's got generalized edema. She has, her labs with the
Yep.
elevated liver enzymes. It's a lack of critical thinking. And it was almost like they had a diagnosis for every symptom the patient had.
Yeah. So let's close up with some final thoughts. Julie, what are your thoughts?
Well, when I listened to your interview with this patient, the first thing that came to my mind is, why are we always starting at zero? We have so many cognitive tools and cognitive aids that can help us. We have maternal early warning criteria, which she met. And if you meet maternal early warning criteria, you should be able to follow that up with another cognitive tool like a checklist or an algorithm that will help you kind of sort through all of the symptoms and figure out what are the tests that need to be done to rule this out or to rule this in. I don't know if it's arrogance, if it's lack of use. I know I've read several articles about checklists, and there is a kind of a resistance to using checklists, and I'm not sure why. I don't sense as much resistance from new practitioners as I do from those who have taken care of patients for a long time, because I think people new to healthcare kind of understand what they don't know. And I think we forget what we don't know the longer we've been practicing. And I don't mean that in a harsh way at all. I think you're just used to doing things. You're used to seeing patients in a certain light. And most of our patients are healthy and they go home healthy with a healthy baby. So when you see something that's out of that range, I think you tend to think, well, this is just a slight variation of normal and you can normalize it. And you don't maybe fully appreciate the fact that this can be a problem and it can escalate quickly, particularly when they're not in the hospital and there is no one watching them like they do in the hospital. I think that was what struck me most about this case.
Yeah. And for me, I think it was the patient perspective that really struck me. I think her having to live with this diagnosis of peripartum cardiomyopathy, again, that's a large diagnosis that impacts your life. And it did hers. I mean, she went to cardiologist, she was medicated, she, had been told you should not have any more children or you're going to die, and that you may die anyway sooner than most, because you may go into cardiac arrest, and all of those things. That's scary. That is so scary to me that I really, that struck me. And let's say she was a primogravid patient, and she wanted more children, let's say, then that would have been the wrong diagnosis would have really impacted her future. And then I think of it from the perspective of, okay, well, she had preeclampsia. That impacts her future cardiovascular disease risk. And she needs to know that, right? And how to follow up for that versus I have peripartum cardiomyopathy. So it's a completely different risk algorithm, that would need to be followed for a different diagnosis.
Yeah, and as a maternal fetal medicine doc, I can't help but think about where was the MFM in all of this. Now, they may not have had access to maternal fetal medicine in this community or in this facility. I don't know. But what I want the listeners to understand is that any pregnant or postpartum patient that's managed in an intensive care unit really should benefit from having a maternal fetal medicine specialist involved. Because if an MFM had come in, there's very likely, I can't say it would have happened, but it's very likely that the correct diagnosis would have been made, or at least more likely that the correct diagnosis would have been made. They would have had a better understanding that all of this fits with preeclampsia with severe features. But even beyond that, any patient, and for those of you patients who might be listening, many of you are medical and are patients yourselves, see a maternal fetal medicine specialist once this is all said and done. Because, I'm commonly reviewing records of patients who come to see me pre-concept, or they're maybe in the first trimester or second or whatever it is, and they give me a history and it's a little bit more vague than I want. And so I request their records, I go over them, and I learn all kinds of things that completely change the patient's perspective of her story, her risk, and how she needs to be managed. So having someone weigh in, like a maternal fetal medicine specialist, before you make irreversible decisions like sterilization or whether or not to have more, enlarge your family or have more pregnancies, these are life-changing decisions. And with the advent of telemedicine, there's more and more of this available now. So it's easier than ever to get a maternal fetal medicine physician involved in your care, even if you don't have them in your community.
Yeah, because that would also impact your birth control options too, so you would want something long term, that, like you said, you don't want to go and have a sterilization or something like that with the wrong diagnosis.
And then the last little comment I'll make is, if you remember nothing else, please don't give respiratory sedative medications to someone with respiratory compromise, such
You don't
as
think?
Haldol and benzodiazepines, because they might not have been headed for intubation, but they're definitely much more likely to end up intubated when you suppress respiratory drive in someone who is struggling to breathe. So
Who's has hypoxemia and,
yes,
struggling, short of breath.
So thanks, guys. I love talking about these cases with you. I learned so much. Hopefully our listeners are learning too. We really just we're not trying to be critical of things that, and be Monday morning quarterbacks. But what we want is for everybody listening to say, yeah, that's happened to me, or I could see how that can happen in my institution. And what can I take from this to provide better care the next time I'm in this or a similar situation?
Yeah, that's the key is these cases, these patients are coming to us and saying, we want to tell our story. And I think that's such an important perspective too. I know I've learned just from listening to them, and Stephanie, you've done a great job at interviewing them, but I've learned so much at their perspective. And I think that's important to hear them and to understand some of the things that they are going through with this and to learn. They want us all to learn, and we all learn every day. We learn every day. Nobody knows everything. We all learn every day, and I know I've learned so much from these cases, and I appreciate these patients coming forward telling their story.
I think what you said is vastly important. We can't all know everything. You can't keep it all in your head. And I know I got sold this myth when I was in nursing school that you had to have it in your head. You had to have all of this stuff memorized, and you don't. We have cognitive aids, we have checklists, we have all kinds of downloads in our academy that will help you navigate these difficult patients.
Yeah, I don't remember the Krebs cycle, so I'll just tell y'all that right now. I couldn't outline it right now, but I could in nursing school.
I'm sure your patients are all better for it.
Yeah, it's never impacted me, but
So thanks everybody for listening. Remember, we have the Critical Care Obstetrics Academy that you can find on our website, clinicalconceptsinob.com. We're constantly trying to run specials to give people more access, so keep your eyes open. Don't forget to subscribe and listen and leave us a review. You can learn more about us at our website. You can follow us on Facebook, Clinical Concepts in Obstetrics, LinkedIn, Clinical Concepts in Obstetrics, Instagram at Critical Care OB, and on X at OB Critical Care. And if you're a patient or you have a story to tell that you want us to consider, or have a topic that you want us to consider having a podcast on, please reach out by email or direct message. Thanks for listening.
This podcast was produced by Austin Baird. Are you looking to create a podcast? Please email me at podcastnashville@gmail.com. That is podcastnashville@gmail.com.